Okay, so this is going to be a review of the integumentary system because I feel like there's always questions about this on the HESI. So just a couple reminders, the order of the skin layers goes epidermis, dermis, which is where all the vasculature is, and then subcutaneous, which is the fatty layer. Make sure to get a culture, like a wound culture, before starting antibiotics so that it doesn't alter the result of the wound culture. Just so you know, culture and sensitivity will be the most accurate, like best way to determine like antibiotics and subsequent treatment. Anytime you're gonna mess with the wound or do anything, make sure you pre-medicate 30 to 60 minutes before, if it's a PO med, before dressing changes. Make sure you do your assessment on the wound, measuring dimensions, drainage, the color, amount, viscosity, the smell, the wound bed, so the deepest layer, and edges. So tunneling using like the face of a clock. The head is 12 o'clock and like feet are 6 o'clock. You want the wound bed to be beefy red because that means there's blood flowing to it. If it's white, it means no blood flow, no oxygen, the tissue's going to die and become necrotic. Wet dressings are best for like exudative, itchy, open wounds. It helps it heal faster. Ointment is the most effective for skin versus like a cream. Ointment is just the best for healing. It's applied in a thin, even layer. Patients with darker skin assess oral mucosa, palms, eyes for pallor or cyanosis, and African Americans may have naturally yellow sclera in their eyes. Okay, so wounds, we have primary healing wounds and secondary healing wounds, throwing it all the way back to fundamentals. This up here is a primary healing wound. We can see that it's well approximated. It has been stitched. There's slight redness, slight swelling. It's probably slightly painful. This is a normally healing wound. Okay, if that redness was extending or you saw spikes of redness coming out, it was very swollen, very painful, coming apart at the edges, you would be concerned of infection, right? But this is just local inflammation, the natural response to a wound such as this. Right here is a healing ridge, and that's just collagen buildup. The things that can happen with primary healing wounds are dehiscence and evisceration. So dehiscence, a lot of patients will describe it as like a pop. They feel like pop open. So you want to look at it and you see that it's popped open, and you obviously want to cover it with the sterile wet gauze and then go tell the provider. Um, but how to prevent dehiscence is you want to give them like a pillow or an abdominal binder to provide counter pressure so that when they cough, sneeze, or something like that, it doesn't put that pressure on their wound and pull it apart. Evisceration, the organ's coming out. The organ is not used to being in a dry environment, so it needs to be covered with a wet, sterile gauze, and then additionally covered with like an abdominal pad to keep it protected, and then call the provider right away because they're going to need surgery to replace that. Okay. Surgeon removes the first dressing. If it's bleeding through, just put another dressing on top and reinforce and continue to do that and apply pressure until it's no longer bleeding through, and then let the physician know. You may also want to mark the drainage and then come back later and see if it's expanded past your markings. Secondary healing wounds are pressure injuries. This is preventable when you help the patient ambulate, passive range of motion, or active range of motion. Turn them at least every 2 hours, frequent brief changes, and using barrier cream when you change their brief. You also want to watch for areas covered in medical tape, devices like oxygen tubing behind the ears or on the cheeks. And you use the Braden scale for pressure injury risk. So this is the Braden scale and all the categories. Pressure injury stages. So stage 1 is unblanchable redness. So you push on the redness and it doesn't turn white. That's because capillaries have burst in that area due to pressure over that bony prominence. Stage 2, the dermis layer is the deepest layer. You can see oftentimes you'll see it blistering. The skin is no longer really intact. Stage 3, the deepest layer is subcutaneous tissue. So anything lower than the dermis is a full thickness wound, just so you know. So deepest layer subcu, stage 3. Deepest layer muscle or bone is stage 4. Unstageable would be necrotic tissue. Cannot see the deepest layer. Needs debridement, or so it could be like mechanical debridement, where the doctor orders a wet to dry dressing. You put the wet layer down, come back later, peel off what's now dry, and it should take the necrotic tissue with. Make sure you give them pain medicine before that extremely painful thing, or it can be surgical scraping. So they're going to go under for that. It's obviously a lot more invasive. Okay, so let's see if you can figure out what stage these pressure ulcers are in. You can pause it and figure it out, but we'll go over it right now. So this one in the left corner is a stage 2, the lowest, the deepest layer you can see is the dermis, and it looks like just a very shallow blister, okay? This one is stage 4, you can see muscle popping through some fascia as well as the subcutaneous tissue laying on top, right? So the deepest layer is that muscle bone. Here you can see that subcutaneous tissue, so this is stage 3, the deepest layer right there. This is stage 1. If you pressed on it, it would stay that same color, but it's still intact skin. And this is stage 4. So there's necrosis covering the deepest layer. So we're not actually sure, or sorry, this is unstageable, not stage 4. We're not sure what stage it is until we remove that necrotic tissue. Okay, so we have some primary skin problems. So the most common ones that I've seen on Hessies is macule. It's flat. Papule is raised, and these are smaller than both of them are really small, smaller than the size of a pencil eraser. The macule is flat, papule is raised. Senile keratosis or age spots are benign. It looks like this right here. See it on a lot of elderly people. Psoriasis looks like these silver plaques right here. It's an autoimmune disorder, and it can turn into arthritis, like psoriasis arthritis. Okay. So these are other primary skin lesions. So a bulla or bulla, collection of fluid. This is our macule, nodule, like really raised, a patch, papule, plaque, like with psoriasis, pustule containing pus, could be acne. Vesicle contains clear fluid, can also be acne. Wheals usually happen during allergic reactions. Scales could be like eczema. Crust is not normal. And then fissure, cracks or split open. Okay, skin cancer. So we see the different types of skin cancer up here. We use our ABCDE acronym for melanoma. So that's asymmetry, irregular border, different colors, diameter bigger than a pencil eraser, so 5 millimeters, evolution changing over time. So melanoma, here we can see that this border is irregular. If we cut this in half, it would be asymmetrical. The color, there is multiple colors going on, and it's not just one color. It looks bigger than a pencil eraser, and it might have changed over time. Okay. Basal cell carcinoma is the most common, least deadly. It's red and flat, like this. Squamous cell is very aggressive. It's colored, it has exudate. You see that exudate coming out, you can see that color going on, and it's raised usually. Merkel cell, it's raised and red, like this. So exposure, so fair skin, the person with the fairest skin who's had the longest exposure is the most at risk. So like the risk of an old white male who works construction for 60 years has a greater risk than like an African American female who uses tanning beds. Even though like tanning beds in my head, I'm like, oh, like huge risk for skin cancer. It is, but fairer skin out in the sun longer. Okay, burns. So burn conversion, meaning burn can start out in stage 1 and become stage 2 because the skin continues burning because heat is trapped inside of it. So the degrees of burns, the first degree looks like a sunburn, second degree, red, blistered, shiny. It still blanches, so it turns white. This is a partial thickness burn. So those blisters, the dermis is the deepest layer. Third degree, it looks leathery and shiny, doesn't blanch, no pain because now the nerves are burned. This is a full thickness burn. Fourth, muscle and bone. It looks charred and white. There's no blood flow. It's probably going to die and fall off. Treatment can be debridement, cadaver grafting, autograft, so coming from yourself on a different part of the skin that hasn't been affected. Cultured epithelial autograft, so they take your skin cells and grow a graft off of that. It takes about 30 days. ReCell spray is supposed to help the cells regrow. Epiburn, same concept, meat grafting. It's just a specialized technique they use to graft skin. This isn't really going to be tested. It's more specialized knowledge if you go into burn units. This is important though. Escherotomy, it treats for compartment syndrome. So sometimes the burn can get so tight on the skin and the fascia and muscle and organs that the pressure and edema underneath has nowhere to go. It has nowhere to grow. And so what happens is they make a cut. So they cut the skin or the eschar to allow the edema room to expand. So it doesn't cause that compartment syndrome. You can also check abdominal pressure if they have like trunk burns with a special gauge on a Foley catheter, which I thought was interesting. They're going to be in protective isolation, so wearing protective PPE. Pain, you want this patient is most likely going to be sedated if this burn is severe enough. So ketamine, fentanyl, Versed, phenobarbital. They have a high nutritional need, so they need a feeding tube and high calorie burn shakes. Okay, fluid replacement and pressure garments to prevent spacing, like third spacing, for like basically the rest of their life. Laser therapy decreases scarring, and obviously mental health interventions because they're going to have some pretty intense anxiety and PTSD after these burns. Okay, so pretty graphic, but this right here, like, see if you can tell which is which. Okay, so obviously this is just a sunburn. This is first degree, but remember, first degree can become second degree if it's bad enough. So this is second degree. The deepest layer is dermis, looks like one big pop blister. This is third degree, looks a little leathery. It's white, no pain. The nerves are burned. This is stage 4. So we still see that burn tissue there. We can see muscle, bone. We still got that white leathery appearance, and yeah, it looks charred and white, no blood flow. Okay. There's different types of burns. One's an inhalation injury. So like what happens when you get trapped in like a burning building and you get that smoke and like inhalation burns. You're probably going to have to intubate this patient and ventilate them, remove their clothes and any evidence of the inhalant still left on their clothes so they stop inhaling it because their airway is a huge issue here. Electrical burns have entry and exit points. Electrical burns actually need more fluids than other burns, which I thought was interesting. Chemical burns, you want to remove the clothes, flush with water. If it's a powder that's burning, you want to brush it off before wetting it because wetting the powder would only make it worse, like a paste of burn, you know? Any facial burns, you want to watch for airway swelling. They're going to need to be intubated most likely. Carbon monoxide poisoning. Carbon monoxide has a short half-life. It's even shorter with oxygen applied. That's why like priority with carbon monoxide poisoning is to apply oxygen. The pulse ox will read 100% because the CO is binding the hemoglobin. So just because they have 100% oxygen sats does not mean they're doing okay. Treatment is hydroxycobalamin. This medication turns the skin cherry red and all secretions cherry red. So their pee is going to look pretty red, like a popsicle. Okay, so percent burned, you can determine this using the rule of nines, which I'll show on the next slide, or the palm method. So every, like your size of the palm, you measure the burns and every palm is 1%. Fluids, initially, they're going to get, if they're less than 5 years old, 125 mils per hour, 250 for 6 to 13-year-olds, and over 14 years, 500 initial fluids per hour. Then you're going to use the Parkland formula to determine actually how many fluids you're going to need per hour after that initial amount. So you use ACE, which is for adults 2, children under 14, 3, and electrical burns 4. Remember, they need more fluids. Times the kilograms times the percent burned determined up here. You give half of what you determined in 8 hours and then the other half in 16 hours. Lactated ringers is the most common fluid used because it has more electrolytes for replacement. For all of this, I wouldn't necessarily say you need to memorize this for exams, but it's definitely good to know, like just that you're going to need fluid replacements. Definitely probably know Parkland formula. A lot of Parkland formulas don't include the ACE portion. That's more advanced, so just do KIGS times percent burned. But definitely know the half in 8 hours and the rest in 16 hours in LR. Okay. So this is a rule of nines. So if they got facial burns as well as burns on the back of their whole head burned would be 9%. For their chest, 9%, genital area, 1%. Each leg, front of the leg is 9%, back of the leg, 9%. So the whole left leg would be 18%, so on and so forth. Okay. Fluid resuscitation continued. We are looking for urine output, right? We're giving them fluids. They should definitely have something coming out, or they're definitely at an AKI risk. Okay. So if they're more than 30 kgs, 0.5 mils per kg per hour, about 30 to 50 mils per hour is good urine output. Less than 30 kgs, 1 mil per kg per hour. For electrical, you want them to be urinating 75 to 100 mils per hour because they are getting more fluids. The chance of survival for a burn patient, you take the percent burned, times it by their age. If it's less than 140, their chance of survival is 50%. So burns are pretty serious. Okay, so practice questions for integumentary. Okay, so positive for MRSA, what precautions did they institute? Wear a gown and gloves. This is contact precautions. Of course, unless you're expecting splashing, then droplet precautions. Okay. Had the burn injury, had in their home basement, an inhalation injury is suspected. What should they anticipate being prescribed? The answer is D or 4, 100% oxygen being a non-rebreather. That's the correct answer. Nasal cannula is not sufficient enough, and aerosol mask. No, it's just non-rebreathers used for resuscitation purposes. Okay, being admitted after flame burns to the face and chest, immediately you should think airway. Okay, has a hoarse cough, expectorating sputum with black flecks, becomes restless, and his color is becoming dusky. They're not getting oxygen. Okay, based on this data, what interpretation should the nurse make? Answer 3, the burn has probably caused laryngeal edema, which occluded the airway. Okay. All right, therapeutic outcome of an escherotomy procedure. The answer is 1, the return on distal pulses, because remember, escherotomy is done to relieve the pressure in the compartment syndrome. If compartment syndrome is happening, it's because there is a decrease in like the 6Ps, right? There's more pain, pallor, pulselessness, those things. Okay, so we want those to return because then we know that that pressure is not compromising their perfusion. Okay, client getting intravenous fluids, has full thickness burn injuries of the back and legs. Nurse understands that which would provide the most reliable indicator for determining the adequacy of fluid resuscitation. Okay, so fluids always go with urine output. What you put in, you should be seeing come out. And that is determined, that determines the adequacy of fluid resuscitation. So if their urine output is low compared to the amount of fluids they're getting, it's possible they need more fluids to resuscitate them. Okay, that is it.